Hello everyone. I am Dr. Ramya Suresh, a member of the Executive Committee and head of the Newsletter Subcommittee of the Karnataka chapter of Indian Association of Pathologists and Microbiologists. PathVarna, the official magazine of KCIAPM, an initiative of the Newsletter Subcommittee, is successfully running into its fourth volume this year. As a part of it, this year, we are here to interview a prominent pathologist, a senior pathologist who has contributed immensely to the field of pathology globally and also to the association. An eminent pediatric pathologist, internationally renowned for her work in Hirschsprung's disease, and heads the Translational Research Laboratory for Gut Motility Disorders at St. John's Medical College. She is an ICMR Emeritus Scientist and the recipient of the Karnataka Lifetime Women Achievement Award for the year 2020. She has been a very close part of the association and served as the past president of KCIAPM. She is the president of the Association of Pediatric Pathologists of India, and a new feather to her cap is being elected as the president of the Indian Association of Pathologists and Microbiologists. A mentor, guide, and inspiration to everyone out there. We are happy to have with us Dr. Usha Kini. Thank you, ma'am, for being with us today.
Thank you, Dr. Ramya. It's wonderful to be here in this lab of the Translational Research Lab, which is the place where I have been working for the almost 25 years and seen it grow to this. So this year has been the Silver Jubilee year, and we are happy and proud that many things coincide together to make this a wonderful day, a moment, and an achievement for KCIAPM as well as IAPM.
Thank you.
Thank you so much.
You must be overwhelmed with the recent win. How do you feel? Talk us through it. What does this mean to you?
Yes, it's something that I just couldn't believe when it happened. It's just not just a victory, but it's so much to it. It shows the trust of the so many in me, in my work, as well as, what they are looking up to, which may be what I'm dreaming of, and hope I would be able to deliver as their president to the chair that I have occupied.
There's
Thank
no
you
doubt
so
about
much.
it, ma'am. I'm sure we're looking forward to
But
a lot
it's a
many
great
more
challenge.
things.
It's the greatest challenge, I feel. Though I had so many challenges in life, but this is something that I'm sure I'll be able to, get over it and achieve what I'm dreaming of and what other people expect of me. But I'm so thankful to all the support and the trust that people have in me, thinking that, yes, I would deliver. That is immense. And that is what I'm sure is going to drive me for the next 11, 12 months.
Looking forward, ma'am. Your name is now on the global forefront, but we all start somewhere. Who or what was your inspiration? How was it growing up? How did you end up here?
Ramya, there's always a long story behind whatever happens of late. But to say, yes, my upbringing, that's what we look up to, but nothing to mention. But I enjoyed my childhood days with my friends, with the nature. Never ever thought that I would get into medicine. And there is so much of hard work ever. I was in bliss. And probably, sort of, I must say, the discipline that my parents had instilled, and they said, hard work, whatever you do your best, excel in what you do, and probably kept me going till I joined medicine. And thereafter, you're into a maze with so many things to study. Yes, I was a very quiet person all through. Never have achieved to be a leader at any moment in my life, except for myself and my family, which I always thought so it could be. But then things started changing shape when I started teaching students. I had good mentors, good teachers whom I adore. They have been part and parcel of my life even to this day. I miss a few who are no more. They have been my guiding spirit, and the things that I have instilled in me, that be true in what you do and be dedicated, is something that I'm passionate. The word passion is something that I see to it that is always there in what I do. So the passion, the hard work, and looking forward to excellence in what I do is something that has taken me this far.
And you are that. You do excel in what you do. We see the passion and we see the hard work. Has pathology always been the field that you've always wanted to do?
No. Not really. And that is because in my undergraduate days, the pathology was taught as a subject. It was never instilled as a specialty wherein you deal with that with your patient. And I got to realize that only when I did my internship. When I examined patients, made a diagnosis, I said to know what I'm really true. That is when I just started looking at the pathology workup of these patients. And more so when I did my residency, that is when, the professor and head at that time, he would say that we need to do the baseline investigations in the side lab, which was attached to the main ward. So the patient would get admitted on day 1. Day 2 morning during the rounds, all the investigation details have to be there. So you know what you have examined, what your differential is, and how would you correlate with the lab details to make the correct diagnosis. So that integration instilled in me made me think, hey, pathology is not what I learned. It is very different.
Absolutely.
So I said, there's something wrong in our curriculum. But at that time, I never thought as the word curriculum because I was still a student then. But now as a teacher, looking back, yes, we were wrong in having that kind of a curriculum where there was no integration between the pathology that is taught in the classroom and the patient on the other side in the hospital. I wish it was integrated, and I suppose I would have run to pathology then and there. But it took a while for me to make up my mind to put pros and cons. And I said, yes, pathologist is the doctor of doctors.
Yes.
So I said, maybe that's well suited for me, as I'm a rather quiet person and I can do my best.
Ma'am, you mentioned about the integration and the curriculum. Now, pathology as a specialty is yet to make an impression on the people as well as the students. How do you think we can change that perception of the field as well as the work involved?
Yes, that's a very interesting but difficult one to answer. Now, to think back, how could we integrate it with others? Yes. Pathology is looked up to as the second year subject. So the students have just finished the first and come to the second, and they are just entering the hospital. Pathology should not be looked at behind the scenes speciality or behind the scene work. Even when taught, it would be nice if we start with a patient scenario and say this is how the patient is. And it would be still better if you can have a patient brought to your classroom and say, here is your patient, and we are going to talk about him. These are his findings, and this is what the pathology has detected. So this is the clinical diagnosis. So I would say that the student should be taught about the so-called pathology as the heart of medicine and is the trunk of medicine, where all the branches are there up only if they have a good pathologist to give an answer to the so many whys, hows, and where and why not. If that is not answered, and I'm sure they wouldn't understand the clinical aspect. So I think pathology is the basis and it must be taught. It can be only done and well done only when integrated. And that happens when we have our clinicians by our side and the other fraternity around us, depending on the case, the real case scenario is brought into the classroom. If not, it's a very passive, non-interactive, just delivered didactic lectures, make no sense to the present generation of students who are want to be so vibrant. I think otherwise pathology will remain a mundane subject.
Absolutely.
We need to change.
What do you think is the challenge of being a pathologist in India?
That is true. To say pathology is a subject so far as a branch of medicine or the way you look at it, which is not much appreciated. It's not yielding. And as you say, or as I say, and many of people say, is just that the pathologists want to be behind the scene. But we should remember as pathologists, we are first physicians.
Absolutely.
We did a 5.5 year course of medicine like any other physician. And why do we forget that aspect of it when it comes to delivering something as a pathologist?
Right.
We never correlate our findings with the clinical. And instead, in all our reports, in our reports, we tend to say, correlate clinically, which is truly untrue. Because here you have a patient, you have someone. Otherwise, you ask the patient to come over to your lab, you examine. We know how to examine, how to integrate. And we should be an amateur radiologist trying to at least put things in place or have a conversation with them as we deal with that case. And they're all just a few seconds away. And with the mobile, the network that we have, it's not difficult to be in touch with them, absolutely. And I always feel a clinico-path correlation is something that every case has to undergo for the accurate diagnosis that we aim at.
Yes,
that should be our goal. The integration, I suppose that is what is going to take us far and wide.
Absolutely.
And then you feel you're part of the team of the clinicians. There's nothing like behind the scene. I practice that every day in all my cases.
Yes.
So every diagnosis goes over the phone with the discussion and what they have to do beforehand before the report goes.
Right.
And that is, of course, supported by the report at the end of the day.
Yes.
Thank
Absolutely, ma'am. Yeah. I think when we ourselves put pathology up there, I think it will be equally seen upon by others as well.
Absolutely. Because we know the diagnosis, we can in fact guide them.
Right. Absolutely.
Guide the surgeon or guide the clinician as to what next to be done if there is no correlation. Maybe this should be done or that, maybe. Why not we think this way? So that way, we're doing our best to the patient. So, as I always say, behind every test, every slide, everything behind the microscope, a life that needs to be saved, that needs to be nurtured, and that needs to be respected. And that can come only if we put in that place and do our justice to what we do.
You have touched the lives of many, many little ones with your work on Hirschsprung's disease. Is there one such experience that has touched you, taught you some lessons that you would like to take with you on your life, on your journey, and what has brought you here as a pathologist as well? Please do share it with us, ma'am.
Yeah. That's a long journey. As I was saying, it takes me back to 25 years. But nevertheless, I was very interested in cytology right soon after my, doing my post-graduation, joining as a faculty. I said that's one field where you can give a rapid diagnosis. The word rapid diagnosis came into effect. The word ROSE came in. And they said the surgeons were thrilled. The clinicians were thrilled as to say, oh, you can give a diagnosis with a prick of a needle. And that used to be fantastic. And they could post the case the next day and see the biopsy results correlating with your FN. That was nothing like it. It was you would get amazed and they say, that is the power of cytology or the FNA or whatever you would like to call it. And I was totally into it. And many others, yes, got into the cytology. I remember how FNAC was instilled, we used to get gross specimens fresh so that we could poke each one of them, make a diagnosis and see whether it correlates with histopathology. That's how we evolved cytology, FNAC in our department. And everything was perfect until one day that we had a frozen from a pediatric case. It was a child. It was a 2-month-old baby who was having constipation. And that would mean nothing to anybody because after all, so what? What is in constipation? It's not just not able to move its bowels a little bit. It's okay, it can, because 60 to 80% of the children have constipation, so with the adults. Why worry about it? But for the surgeon in a pediatric surgeon, things are very different. It boils down to diagnosing easily about 10 to 15 cases. It could be medical and surgical. And when a surgeon looks at that case, he would like to differentiate between a medical cause and a surgical cause. So you have a 2-month-old baby. So you would like to say if it can be just treated with medicine. But at the same time, you need to rule out a surgical cause.
Right.
Because after all they can present is constipation. They're not like adults who can express. So it is different when you look at pediatric versus adult. And the frozen came in. And this is 25 years ago when you had your cryostat, which was not as robust or whatever you call it as we have now, which was so high-tech. Now it freezes in just about 1 minute, 2 minutes, your section. But we had to wait for 5 minutes. The time runs on. It's a baby on anesthesia. So anyway, we cut our sections, we look at them. And at that time, I was just a lecturer, got into as an assistant, promoted as an assistant professor. And then I had my senior professor who would be reporting on frozens and who is the, would say, expert on all this. So, and the diagnosis was made saying that this biopsy which was sent from the perrectal, it was not ganglionated. So that means to say, when we say no ganglion cell, it would equate to Hirschsprung's. So the surgeon continued the surgery. But it takes a while for the completion of the surgery. In the meantime, my professor, as was the customary, would relook at all the frozen sections in the little free time that they would get, because they believed in perfection. And to say the last section in the series showed a ganglion cell. So she was taken aback, and she called up the surgeon and she said, see, I find that there is a ganglion cell in this last section. So it may not be Hirschsprung's, I'm sorry. But then the surgeon had finished the surgery. The resection was done, and the operation was almost done. So that was something that I couldn't swallow. The diagnosis that was made at that moment is not because of lack of expertise, lack of technology, I would say. I said we didn't have something which would give us a foolproof diagnosis in that little short time that we have of 15 to 20 minutes. It's humanly impossible to look at 60 to 80 section as it is mandatory to make a diagnosis of Hirschsprung's. We couldn't do that on frozen. But the surgeon's needs are such. So he would expect you to make a diagnosis. He wouldn't know that you can't make it. So that gave me a jolt. And I said, yes, there must be something that we can do on this to make things easier for the pathologists, to make it user-friendly, and have 100% specificity in your diagnosis so that it is foolproof and surgeon can go ahead with the surgery then and there, without looking for a final report on a paraffin section, which would take 2 to 3 days. So that was the changing scenario for me. I switched from cytology to this entity and took quite a bit of my time, 2-3 years, trying to understand everything about it, because there was no single center in India which would be dealing with it. This was an era when we had no internet. We had to go to the library, look for articles. Some are available, some were not. But that was when we decided, yes, this is the area that needs the thrust. This is truly translational. And this is going to make a great impact on small little babies. And that would be a great benefit for the pediatric age group. So that brought the evolution in the diagnosis of Hirschsprung's, which I say in our institute and then in India. And I'm happy and proud to say I was the only diagnostic center which handles all frozen section reports, which go in 20 minutes, which is with ancillary techniques, which would be about altogether 30 minutes. And that we don't wait for permanent sections anymore for anything.
That's incredible, ma'am. We are all super proud of you for the way you have changed the diagnosis and hence the treatment for Hirschsprung's and all the little ones out there who are in need. Thank you so much for that. Have you had the opportunity to interact one-on-one with any of your patients?
Oh, yeah. We have a whole lot of them. Actually, we talk to them, to the parents, not once. At least they do visit us 3 times till the baby undergoes the final surgery and they go back home for good. But we keep track of them. We have their data, especially their contact numbers. And we have now patients who have reached, they are in one baby now has grown up and he's doing medicine.
Wow.
So we are in touch. I'm sure they're all the parents especially do keep in touch with us once in a way with greetings on occasions, drop in sometime. And it's nice to see them that the babies are doing wonderfully well.
It's absolutely very nice, ma'am. Beautiful.